Consortium monthly webinars. Dr. Cho is Director for Institute for Personalized Medicine, Professor for Genetics and Genomic Sciences, and Professor in Gastroenterology at Mount Sinai School of Medicine. Dr. Cho joined Mount Sinai in 2013 from Yale University, and she has been the senior researcher who first reported associations of NOD2 to Crohn's disease. She leads many multi-site consortium efforts to define the risk of gene-associated associations with IBD. We have been very lucky to have her at Mount Sinai, and she's mentor to many Judy investigators. Her research has been funded extensively by NIH, Crohn's Colitis Foundation, and Burroughs Wellcome Fund. I know many patients of IBD, Crohn's, and UC have a lot of questions about the exact risk of genetics and how much the genes are responsible for passing on the risk to their either siblings or their kids. So I know there'll be many questions, and we're eagerly looking forward to the talk from Dr. Judy Cho. Without further ado.
Thank you, Ashish. It's my pleasure to be here. So I'm going to share a file that the folks that are on can see. Can people see the slide?
Yes, we can.
Yes, I can see your screen fine. And
Okay.
just a reminder to folks who are on the audio line that they're muted right now, and we'll unmute the lines at the end for any questions if you want to ask them.
Great. So I'm going to be talking about the genetics of inflammatory bowel disease from a patient perspective and what the implications are for therapy and personalized treatment. So this is in GI practice. I think most patients on the line understand this, but I thought that we would start by understanding that in GI anatomy and physiology, it's quite standard to examine the nature of the intestinal mucosal surface by an upper or lower colonoscopy or endoscopy. And one of the most valuable parts of an endoscopy is that you have these dials that allow you to steer the tip and move the endoscopy through the intestine. And importantly, there is a port for the biopsies, so that this is the look of what a stomach looks like when you're tipping the scope of the upper scope to look at the top of the stomach. And so this fiber optic endoscopy has really revolutionized GI practice and our capacity to follow patients with inflammatory bowel disease. And so, again, just to give people an idea of the pictures of what you see in a small intestine and a large intestine, one of the middle parts of the small intestine is known as the jejunum. And the most common area for Crohn's disease to be involved is the ileum. And then again, when you take those biopsies through that endoscopic port, we then fix it so that the pathologist can look at what the intestine is looking like under the microscope, either with the small intestine here or the large intestine here. Now, what distinguishes the small versus the large intestine is that the large intestine has what we call are these crypts, and then the small intestine has both these absorptive villi as well as the crypts. So that's some basics in terms of what's going on when we look at the endoscopy in inflammatory bowel disease. Now, the intestinal immune system is the most extensive immune system of any tissue of the body. So again, small intestine here with the villi and the crypts, large intestine here. And importantly, we think that what causes inflammatory bowel disease is the interaction between genetics and the intestinal microbiome, which are bacteria, fungi, viruses that normally exist within the lumen of the small intestine. And the key part with that we think drives inflammatory bowel disease is how the host's intestinal immune system is designated by these inflammatory cells within the intestine interact with the microbial milieu that exists within the intestine. And this is what drives inflammatory bowel disease. So normally these bacteria that exist within the lumen, we coexist with them in a healthy situation. And normally under health, the intestine is covered by this protective mucus layer. And then importantly, you have a single cell epithelial layer. And what really drives inflammatory bowel disease is overactivity of these mucosal immune cells that we'll talk about in the next slide. So the intestinal immune system is the most extensive of any tissue in the body. So again, I think most people on this line understand that inflammatory bowel disease, or IBD, is comprised of two major subtypes, ulcerative colitis and Crohn's disease, that are distinguished by the distribution of inflammation. Ulcerative colitis always involves the rectum. This is what it looks like in endoscopy. So you have a superficial inflammation, a salt and pepper appearance, and it can involve any distribution of the colon. Always involves the rectum, can involve only the left side of the colon, or it can involve the entire colon. In Crohn's disease, the most common location of involvement is the last part of the terminal ileum, or of the small intestine, known as the terminal ileum. But Crohn's disease can involve any part of the GI tract. And the distribution of Crohn's disease often occurs as a more deeper type of inflammation. So one of the clues in terms of the genetics is that you can have families where more than one member is affected by disease. And so that observation many years ago was the basis for all of the genetic studies which followed. And if you look at those families where you have more than one member affected by inflammatory bowel disease, in some cases, in about 25% of the cases, all of the family's members in the family only have Crohn's disease. And another 25% or so, all the affected members with the family only have ulcerative colitis. But you have many families where different members of the families, one have Crohn's disease and another have ulcerative colitis. And so what that suggests is that many of the genes that underlie inflammatory bowel disease confer risk to both Crohn's disease and ulcerative colitis. And that's what we found so far. The peak age of onset for inflammatory bowel disease is anywhere from 15 to 30 years of age, so late childhood to early adulthood. The course is often waxing and waning, where you have sometimes active episodes of inflammation interspersed by periods of relative quiescence. And the work from our laboratory plus many other laboratories through genome-wide association studies, or GWAS studies, we've looked and identified about 200 regions within the genome which contain genes that contribute to inflammatory bowel disease. And a very important observation is that there is a higher prevalence, or there's a higher fraction of individuals who have inflammatory bowel disease of Ashkenazi Jewish descent. So I've showed you this slide in terms of the normal intestinal histology before. So this is what a healthy intestine looks like. You have these absorptive villi in the small intestine separated by these crypts. And then these little dots that you see are all those immune cells within the intestine. And that this is what the healthy large intestine looks like, where you have these crypts that are nicely ordered in what we call a test tube appearance. So you see the crypts that are aligned in a very ordered fashion here under normal intestinal physiology. But what happens in ulcerative colitis is that because of the chronicity of the inflammation, you have a reordering of the architecture of the intestine. And you can see, if you compare this slide with the prior slide, it's normal to have some immune cells within the intestine. But in the case of inflammatory bowel disease, you have a marked expansion of this area within the intestine that you can see by biopsies, where there are just too many of these immune cells or too many of these inflammatory cells that then result in the excessive inflammatory process that we know as inflammatory bowel disease. So there's a spectrum of IBD. Most cases of inflammatory bowel disease are what we call polygenic, where there are many, many of these loci, in some cases 200 loci, that all confer a very small risk individually to confer diseases. In other cases, you can actually have, and these are very rare cases, where you can have single gene forms of inflammatory bowel disease, where you can see that one gene by itself is sufficient to cause disease, And those are the very small minority of cases of IBD. Oftentimes, people who carry these single gene or Mendelian forms of inflammatory bowel disease often present with inflammatory bowel disease very, very early on, almost at birth or less than the age of 2. So the vast majority of cases of IBD are these polygenic forms. But studying these single gene forms of inflammatory bowel disease are quite useful. And so this is the whole spectrum of these diseases. And so what we're plotting here on this x-axis here is the age of onset of IBD. And this is the case in this bottom row here. We're showing individuals in the typical age of onset. So as I said in a few slides ago, most cases of IBD, the peak age of onset is somewhere between the ages of 15 and 30 years of age. So this is the most common type. But in those very rare forms of inflammatory bowel disease where a mutation of a single gene, and these are all the examples of this, you can see that these individuals that carry these single gene forms of IBD present at a much earlier age of onset. And these are what we call some types of these single gene forms are kind of immunodeficiencies and chronic granulomatous disease as well. So the genome-wide association studies that I talked about earlier have been primarily identified by comparing the genetics of individuals that have the disease versus individuals that don't have the disease. And this is what we call a case control study. And these studies involve genotyping several 100,000 SNPs throughout the genome. And what these genome-wide association studies have done, so in here we're showing Crohn's disease, and this is what's known as a Manhattan plot, is that they've implicated certain regions of the genome, such as NOD2 that Ashish talked about earlier, interleukin-23R, which is another major genetic association signal, autophagy, and the prostaglandin genes. So we've identified a number of inflammatory pathways that contribute to these polygenic, more common forms of inflammatory bowel disease. And in particular, I want to talk about the IL-23R associations because this has had implications for the development of new therapies in inflammatory bowel disease. Now, as opposed to the NOD2 associations, which are specific to Crohn's disease, the interleukin-23R, which is a cytokine receptor, is associated with both Crohn's disease and ulcerative colitis. And importantly, one of the most important polymorphisms or genetic variants that we identified was for a protective allele, whereby if you carry the protective glutamine allele, you're 2 to 3-fold protected against developing inflammatory bowel disease. Now, this pathway is very important because it is a pro-inflammatory pathway. It's associated not just to inflammatory bowel disease, Crohn's disease, and ulcerative colitis, but it's also been associated to psoriasis. And so this is a pro-inflammatory pathway. And importantly, those individuals that carry the glutamine allele that protects you against developing inflammatory bowel disease, this glutamine allele is a relative loss of function relative to the wild type allele that most individuals carry. And so what this tells us is that if you block the IL-23 pathway, that's going to be effective in the treatment of inflammatory bowel disease. And this is one of the major kind of associated signals that we see. Another point to be made is that the immune system exists for both good and bad. And so the good parts of the immune system, which is absolutely essential, is that it allows us to fight infections. And so the immune cells that are stimulated by IL-23 allow us to fight a bacterial skin infection, such as Staphylococcus, shown here on the chin. Also, there are these surface infections, such as a fungal infection that can cause thrush. And so a lot of times this inflammatory system is actually good for you, and it allows you to fight infections. But when the inflammatory system is too active, it can result in either IBD, or here's a case of inflammation of the skin known as psoriasis. So the inflammatory system, so as we treat patients, is always trying to maintain that balance between controlling inflammation and trying to avoid the risk for infections. So across different inflammatory diseases, so inflammation of the joints, inflammation of the central nervous system, inflammation of the skin, inflammation of the spine, as well as inflammatory bowel disease, there are different types of methods of targeting these pro-inflammatory cytokines. And so most of us know that blocking TNF works to treat a wide variety of different inflammatory diseases, including inflammatory bowel disease. And so the new drug that we're very excited on, that the genetics has helped provide some insight on, is that blocking the IL-23 pathway, another pro-inflammatory pathway, has already been approved. This dark green indicates that it's already been approved for the treatment of psoriasis as well as psoriatic arthritis. And so far, both the phase 2 and the phase 3 studies have been very promising in inflammatory bowel disease. And so very shortly, this will be a completely new type of therapy that will be effective, that will probably be approved in the not too distant future, a completely new type of therapy to treat inflammatory bowel disease. Interestingly, there's another pro-inflammatory cytokine known as interleukin-17, which is already approved for the treatment of psoriasis. There have been positive studies in other diseases, but importantly, blocking IL-17 actually makes inflammatory bowel disease worse. So while there are lots of similarities between psoriasis, the inflammation of the skin, and inflammatory bowel disease, there's also some very important differences. And again, the genetics have helped inform us of those differences. And so this is basically a study that shows that, again, I think that anti-IL-17, although it's already approved for the treatment of psoriasis, actually made the Crohn's disease worse. So in conclusion, the genetic associations have identified new therapeutic targets. So we've identified 200 loci. I've highlighted the IL-23R association because it really has had immediate relevance for the development of new therapies that are on the horizon to treat inflammatory bowel disease. The other point that I want to make is that most cases of inflammatory bowel disease are polygenic, so that there is definitely a familial form of inflammatory bowel disease, and that IBD is more likely to occur in family members, but still the risk of family members is quite low. And again, I'm happy to take questions on that. It's going to be less than 5%, even if you have a first-degree relative with inflammatory bowel disease. There are some very rare cases of very early onset inflammatory bowel diseases, typically where children present with less than 6 years of age and often less than 2 years of age, where we think that sequencing the whole genome may actually be interesting to identify those patients that might have to have different types of therapy. But these very early onset cases of IBD are the exception. Most cases of IBD are polygenic, and the peak age of onset is between 15 to 30 years of age. And the final point, which again is only clearly at the research stage at this point, is that genetic information will increasingly be returned to patients. My prediction is over the next 10 years, some type of genetic information will get returned to patients, and so becoming familiar with some of the basics of human genetics, that there are some very rare cases where one gene is enough to cause diseases, but most cases these are just kind of susceptibility genes. So some increased genetic understanding on the part of patients is going to be required for us to really be able to personalize therapies for individual patients most effectively. So that's the extent of what I wanted to talk about, and I'm happy to open this up and take any questions from the audience.
Great. Thank you very much, Dr. Cho. Dr. Atreja, are you with us? Sorry, go ahead.
So this is great, Dr. Cho. I will encourage anyone to ask questions related to genetics, IBD, the future treatment that's coming, or even the risk that many patients are worried about, the risk that goes on to their kids or what their siblings may have a risk for. We'll open the floor for any questions, and then you can guide patients what are potential ways to ask questions.
Sure. I'm going to unmute the lines. There are a fair number of folks, so if you have background noise, feel free to mute yourself after you've been unmuted. To start us off, someone has typed in a question. Is there a genetic test to know if your children will get IBD?
So that's a great question. The genetic testing is right now being used most commonly in those very early onset cases of inflammatory bowel disease. And so we're recommending that if a patient presents less than 6 years of age or less than 2 years of age, where you can have those single gene forms of inflammatory bowel disease.
Katie, grab me another piece of paper.
That it does make sense to sequence in a young baby. Now, in terms of the question of whether if someone in the family has inflammatory bowel disease and you want to predict the risk in your children, we're currently not recommending that. And so currently there are the biggest single risk for the polygenic forms of inflammatory bowel disease is for NOD2, and there in fact is a commercially available test from Prometheus to check for the NOD2, and I think there's other genetic variants where you can actually check a genetic risk score. Now, it's very early days, and typically we're not recommending that. Simply because there's no established tests or approaches to prevent treatment. And the other factor is that the large majority of Crohn's patients actually don't carry NOD2 mutations. So if the proband or the index case in the family doesn't carry NOD2, the fact that the children in that family don't carry NOD2 provides no predictive power. If, on the other hand, if the proband of the family does carry NOD2, there probably is predictive power in genetically testing the children. If the children don't carry the NOD2 mutations and the index case does, there's probably some predictive capacity that says that the children are at less risk for Crohn's disease. But having said that, a fundamental principle of medicine is that you don't order a test unless it somehow changes therapy. And because we have no proven mechanism for preventing Crohn's disease, we're not recommending genetic testing in currently unaffected family members.
Great. We have another question that was typed in. Is there genetic analysis that could identify which patients benefit from earlier intervention?
So that's a great question, and I think it reflects probably an earlier webinar on the importance of early intervention. So there's early intervention in a diagnosed individual, and in the case of someone who's diagnosed with inflammatory bowel disease, we here at Sinai believe strongly that you want to get that inflammation under control with evidence of mucosal healing as quickly and expeditiously as possible, and that's regardless of the genetics. Where it gets tricky is that we're extremely interested in Mount Sinai from a research perspective, not a clinical care perspective, but from a research perspective, in first-degree relatives of IBD probands or index cases we're seeing evidence that the immune system is abnormal in undiagnosed family members who have evidence of immune dysfunction, for example, as evidenced by having the high antibodies against ASCA, so that's a Crohn's antibody, or ANCA, that can occur years before someone is actually diagnosed. So we know that the immune system is abnormal for years before someone's diagnosed, and so that's the really compelling question. But again, that's research, it's not clinical care, because there's nothing of proven benefit. So, to conclude and just summarize what I've said, in a diagnosed patient, early intervention, absolutely important for all patients, regardless of the genetics. In the case of the family members who are undiagnosed, who may have evidence of elevated antibodies, but no clinical evidence of disease, the genetics may help inform us, but only in a research setting, not for clinical care.
Mm-hmm. Great, thank you. I have another question typed in, and the question is, will IBD affect my ability to become pregnant? And perhaps that leads into the question of, how specific has the science gone in terms of genetic risk factors, what sort of things patients should be on the lookout for, or maybe at higher risk for, things that may exacerbate their condition? Do we know any of that yet?
So in terms of the ability to get pregnant, the key thing is to have disease under control. In someone who is under close medical supervision, who has their disease under control, fertility starts approaching the normal population. So absolutely, if someone is sick, malnourished, your fertility is decreased. So, and then in addition, in terms of outcomes to the baby, the outcomes to the baby are the best if, again, you're under complete control. And again, this is Marla Jabinski has a prenatal clinic, and so the key is to you want to conceive when you're under good control. In that situation, fertility is very good. And then in terms of continuation of medications during pregnancy, again, you need to do this in conference with your physician. But again, the key is the medications, TNF, that kind of got you under control, anti-TNF medications are perfectly safe during pregnancy. And so the most important thing during pregnancy is to keep the inflammation under control, and that's the way you have the best outcomes for the baby.
Great. I have another typed-in question asking about current studies for IBD genetics that this person could participate in. And I don't know if they're a patient here at Mount Sinai in New York or not. But maybe.
So if someone's interested in participating in genetic studies, we're happy to take them. And I'm blanking on our listserv thing. So I'm happy to be emailed directly, judy.cho at mssm.edu. We are able to, even if they're not at Mount Sinai, we very routinely can either accept blood long distance, or if a patient prefers a saliva sample long distance. We have a number of very active genetic studies. We're particularly interested in the genetics of Ashkenazi Jewish individuals. I didn't get into this, but some of the less common genetic variants are going to be population specific. And so some of these rare risk alleles, we're increasingly able to identify them in Jewish populations. And so we're particularly interested in recruiting patients. And again, feel free to email me. I probably, again, I don't know if you can disseminate my email. And then we're happy to forward it to my study coordinators. And we can either take you at Mount Sinai or long distance. And again, there's a number of reasons to do genetics. The reason why the primary reason why we do genetics is that every single one of those genetic loci, in my opinion, represents a potential new therapeutic target. And so, we've combed through those 200 loci to truly identify really new methods for kind of therapies. And so that's the primary reason, in my opinion, to do genetics. A secondary reason, which increasingly as we get more sophisticated in this, is to really start trying to assess risk in family members. But that's, again, very early days. But we would, again, welcome people, and in particular for the family prediction studies, we're most interested in those So for the general genetic studies, we will take DNA from anyone. For the prediction family-based studies, we are particularly focusing on those families where we have 3 or more members affected by disease, and then trying to fill out the entire family. And then for that part, we're also interested in getting stool studies from the unaffected family members. So it's quite complicated, and I probably, again, I'm happy to kind of take people's emails, and then I'll forward the information to our study coordinators to provide more information on this. But there's a number of genetic studies that we would welcome people's participation in.
Oh, wow.
Great.
Wow.
So if anyone on the phone has a question, you don't need to identify yourself so we can preserve anonymity. But if you do have a question, you can feel free to ask it now. We're getting a lot of thank yous, Dr. Cho, folks who have said this is very exciting, that they haven't been familiar with what's happening, so it's been great to see. If there aren't any questions on the phone, I have one last question that's been typed in. And that is there evidence that genetic variation in patients with IBD plays a role in determining how sick a person becomes?
So the strongest data is with NOD2 again, and that's why there might be value to the Prometheus genetic test. Again, I probably should give full disclosure. I've not received any funds personally, I don't know, for the past 10 years on the NOD2 test, but I was involved with Prometheus on the NOD2 genotypes. So the individuals who carry either the NOD2 frameshift mutation or carry 2 mutant copies of NOD2 are at increased risk for developing what we call stricturing complications in Crohn's disease that involves the last part of the small intestine or the terminal ileum. So there is very consistent evidence that either the carriers of the frameshift mutation or people that carry 2 mutant copies of NOD2 go to resectional surgery earlier and have more evidence of the stricturing or fibrostenotic types of Crohn's disease. What's not been proven, so that's very well established for the last 10 years. What's a logical conclusion from that is that if you are carrying the high-risk NOD2 variants, maybe you should undergo more stringent therapy. And so maybe you should consider being on anti-TNF earlier. Again, that's a decision that must be made in consultation with your physician. But that's not been proven that giving anti-TNF earlier to the high-risk NOD2 patients actually prevents the disease complications. So it's hard to prove these things, and the best evidence for kind of a more severe outcome with earlier complications is with the NOD2 risk genes.
All right. So I think on that note of being sensitive to everyone's time, we'll we'll thank you, Dr. Cho, for making time to speak with us. I think it's been very valuable for folks. I'm hearing a lot of positive things about participating, and thank you to everyone who made the time in your busy schedules this evening to join and listen in and learn more about the genetics of IBD. If you have any final thoughts, Drs. Cho or Atresia?
I would like to thank Dr. Cho. I think this topic has been quite of interest to the participants. And as a reminder, I will tell everyone that we are recording the webinar and we'll make it available through the newsletters and the HealthPROMISE website. On that note, I'd like to thank all the patients, family members who have joined in, a few researchers, and Dr. Cho.
Well, thank you. It was my pleasure to participate.
Great.
Thanks, everyone. And a reminder, we do these on a monthly basis, so we'll be back next month with the next edition of the HealthPROMISE webinar series. Thank you.
Thank you.